Hello everyone, welcome to the topic of leukemia. We're going to have a general overview of what leukemia is all about. Well, let's start with the definition. What exactly is leukemia? The definition of leukemia is simply cancer of the blood. It can get easier than that, especially cancer of the bone marrow. Well, wait a minute, what does the bone marrow do? The bone marrow makes white blood cells, correct? Good. Also makes red blood cells and has megakaryocytes that make platelets. So when we have cancer of the white blood cell lineage, we know we are dealing with a form of leukemia. So definitely the definition of leukemia is the malignant proliferation of abnormal white blood cells, which is found inside the blood, right? So let's write that down. It's a neoplastic, which means it's a cancer. Proliferation, which means they're growing very, very, very fast, of abnormal white blood cells. Now the problem is, these abnormal white blood cells, they tend to accumulate inside the bone marrow and then they overcrowd the entire population, thus affecting normal white blood cell productions. What are the white blood cells we need in our body, right? We call them leukocytes, right? They're neutrophils, the macrophages that fight out infections. We have the B cells, right? The T cells. We need these B cells to make plasma cells, which make antibodies. Unfortunately, once the white blood cells lineage gets affected and they become cancerous, they become abnormal. That means they can become normal white blood cells. As they accumulate and overcrowd the bone marrow, it's going to affect red blood cell production, which is going to cause the patient to become anemic, and also affects the platelet line, preventing platelet production, which leads to thrombocytopenia. So how do we classify leukemias? Well, we normally classify leukemias into two ways. Let's break that into two. There's acute leukemia and there's chronic leukemia. Well, if the granulocytes or the monocytes are affected, we call that myelogenous leukemia. So we can have acute myelogenous leukemia, also known as AML. But remember, this is when the granulocytes or the monocytes, remember monocytes are going to make macrophages and granulocytes are your neutrophils, they're affected, that's called myelogenous, that's AML. And we can also have chronic myelogenous leukemia. See that? So both of them, they're both myelogenous, right? They have an M in there, which means the granulocytes or the monocytes are being affected. However, if the lymphocytes, right? Remember, lymphocytes are your B cells, your T cells. If it's a lymphocytic distribution of the leukemia, we call that an acute lymphocytic leukemia. See that? The word lymphocytes, probably a B cell or a T cell. And if it's a chronic form, we have chronic, it's an error, that's acute, correct? And this will be chronic lymphocytic or lymphoblastic leukemia. So those are the four kinds of leukemia that we have: AML, ALL, and CML, and CLL. Now, the maturity of these cell lines is often affected because once they become cancerous, we cannot make normal white blood cells anymore, and also can tell us what the rapid progression of the disease is. So let's take a look at acute leukemias. Just acute leukemias. The difference between acute leukemias and chronic leukemias is often due to the rapid progression of the disease. What do I mean by that? We have immature white blood cells in the blood. The name of those are called blast cells. Blast cells. So every time you hear blast, think of immature cell lines, right? Immature white blood cell lines are known as blast cells. In acute, anything that's acute in medicine is a very short duration of time. So acute leukemias usually happen with a rapid progression, rapid growth of this immature cell line known as blast cells. And this often affect them before the cell lines become mature. Now, compared to chronic leukemias often affect mature cells. So the white blood cells are already mature at this point compared to acute leukemias, which affect blast cells, which are immature. So always think of acute leukemias of kids that are immature. Think of chronic leukemias when people are adults and they have grown up, and that's the kind of cell lines that are going to be affected. So let's talk about general evaluation of just patients with leukemias in general. Well, because of this abnormal white blood cells affecting all the cell lines in the bone marrow, what are you going to think? Well, they're going to be sort of pancytopenic. What is that big fancy word for? Well, pancytopenia means their white blood cell lines is down, their red blood cell lines is down, which causes anemia, right? And when you have their white blood cell lines are not functioning properly, we call that leukopenia, and the platelet counts are low, making them thrombocytopenia. So these are their general characteristics. They get all three cell lines: leukopenia, anemia, and thrombocytopenia, which means they have low platelets, low hemoglobin count, and they have low white blood cells. Because they're always going to be leukopenic, because the white blood cells they have are not functioning properly, right? They can't really mount an immune response to any antigen or bacteria. What's going to happen to their ability to fight infections is going to be very, very low. So they are very susceptible to infections. Because they don't have red blood cells, right, being produced, and they're anemic, they're going to have signs of fatigue, tiredness, shortness of breath on exertion, right? They're going to have pale conjunctiva because they are anemic. And when their platelet counts are low, you're going to see signs of petechiae, ecchymosis, or purpura. And because they don't have platelets to allow them to form the primary hemostatic plug, every time they get a little trauma, they're going to be bleeding from their joints, bleeding in their gums, bleeding in their mucous membrane. They can have a GI bleed depending on how worse their thrombocytopenic episodes are. It means they're going to have easy bruising. Also, they might have some fatigue and weight loss, and that's always going to fall under anemia. And that will be the general overview of just what leukemia is all about. Now we're going to take it one at a time, what we need to know about each of these leukemia, starting with acute leukemias. So what does acute leukemia involve? Our next lecture will be on acute leukemias. Acute leukemias can be broken down to acute lymphoblastic leukemia, known as ALL, and acute myelogenous or myelocytic leukemia, known as AML. Now, the most important thing you need to know about these leukemias is age. If you memorize the age, you will be fine, because you're not a hematologist. So I'm going to give you the most important points you need to understand. What age are patients most likely develop ALL. They're usually less than 15 years old. So that's what you want to remember. Less than 15, ALL. And for AML, the age is between 15 and 19 years old. That is a very, very important number you have to commit to memory. Less than 15, ALL. So let's talk about ALL. Well, what is the definition of ALL? Remember, it's acute, so it's a very, very short amount of time, but that's not really the case. Acute means immature cell lines are going to be affected. And let's look at the word, lymphoblastic. So what are you going to expect it to affect? It's going to affect the lymphoblasts, which are the lymphocytes, but not the regular lymphocytes. These are early lymphocytic precursor cells, right? So the cells that are going to come before we make the lymphocytes. What are the lymphocytes? We have B cells, right? B cells and T cells. But because we're going to affect the precursors, which means the cell that are going to be presiding before we reach the mature B cells, that means it's going to affect the pre-B cells, see that? Or the pre-T cell lymphocytes. That's why we say it's a form of leukemia that affects immature, because they're not mature yet. These are the mature guys. These are the immature lymphocytic cell lines. So, but what I want you to also remember is ALL is by far the most common kind of leukemia in the United States. Don't forget that. It's the most common kind of leukemia, especially in age less than 15 years old. Another thing you need to know about ALL is that it loves to respond to chemotherapy. So this is how I remember which one responds to chemotherapy. L stands for love or likes to respond to chemotherapy. So responds well to chemo. Just put the like button. Good. Because when I get to AML, I'll tell you it's not very, very responsive to chemo. So what else do we need to understand about ALL? Well, ALL has risk factors, and the risk factors are usually patients that have Down syndrome. Down's syndrome. And the way I remember Down syndrome associated with ALL is because we all fall down. And see, fall has ALL, Down syndrome. We all fall down. That's a beautiful mnemonic to remember. Patients that have Down syndrome always are predisposed to developing acute lymphoblastic leukemia. Also, if you're exposed to radiation, because radiation causes free radicals and which damage our DNA, can affect this cell line and predispose them to develop ALL. Now, remember I told you it affects the pre-B cells? Well, we have to talk about what kind of pre-B cells cluster designation are being affected. And for pre-B cells, the cluster designations are 10, 19, and 20. So CD means cluster designation 10, 19, and 20. And the pre-T cell line cluster designation cells are CD2, 3, 4, 5, 7, and 8. 2, 3, 4, 5, 7, and 8. Those are the pre-T cell lines that are being affected in ALL disease. And those are the cells. Also, there's something called a TDT positive cells. What is TDT positive cells? TDT positive. TDT stands for terminal deoxynucleotide transferase positive. Well, when we diagnose ALL, we find cell lines that have this enzyme in it. This is actually a specialized DNA polymerase. Remember from basic molecular biology, DNA polymerase is found in our cells and is the enzyme, right, the protein that catalyzes DNA reactions, right, to make more DNA. Well, pre-B cells and pre-T cells have this protein in them, which is the specialized DNA polymerase, and its job is actually to add nucleotides. Let's look at the name of the word itself. Terminal, which means the end. So let's say this is remember, DNA starts from 5' to 3' end. And this is the other DNA molecule, 3' to 5' end. Well, TDT's job is to add nucleotides to the 3' terminal end of the DNA molecule, especially in the VDJ region of the heavy chain of the exons in antibodies. And this is usually during gene recombination, which enables for junctional diversity, which simply means in English that this enzyme adds nucleotides to the end of to the VDJ junction of the heavy chain inside the antibodies. Remember, this is what antibodies look like, right? So the heavy chain of the antibody, its job is to add the nucleotides in there because we can have junctional diversity, so we can make different forms of antibodies, especially when we are making antibodies from plasma cells, which comes from B cells. So when you have a TDT positive enzyme, that is usually what we detect in cells that are cancerous in ALL. And it's also known as CALA positive. CALA positive. That's another word for the TDT. All right? So it's also, it's also CALA positive. Now, usually children with ALL might just present with very, very mild symptoms. They might just have fever, throat pain, bone pain with a huge spleen, and that might just be their presentation. But you have to detect it by doing a bone marrow biopsy to be able to see these immature cell lines inside ALL. Now, remember, this disease is very, very responsive to chemotherapy. However, it could have a bad prognosis if the patient is less than 2 years old or they're greater than 9 years old. And also, if their white blood cell count is greater than 10 to the 5th power, if their white blood cell lines, so it's TDT positive, and if white blood cells are greater than 10 to the 5 millimeter cube, or they are less than 2 or greater than 9 years old, they might have a poor prognosis. So before we talk about clinical features of both acute leukemias, let's branch over and talk about acute myelogenous leukemia. Well, in acute myelogenous leukemia, I told you the age is very important, right? 15 years old. 15 to 19 years old is the age group that this disease is most likely common. And acute myelogenous leukemia is characterized by the famous hour rod cell. So let me draw that on the board so you can see what an hour rod looks like. An hour rod cell looks like this. And inside the hour rod cells, you will see little rods in there. Those are called hour rods. And this is the diagnostic histopathology that we always see in patients with AML. AML, hour rods. AML, hour rods. Now, usually there's a FAB classification of AML, and there are about 6 classifications, but I'm only going to tell you the most important ones that you need to remember. The most common one which you need to remember under AML is the M3 type. the M3 type of AML. And the reason is because this disease has tons of Howard rods in it, a lot of Howard rods, and it's noted for the translocation 1517. The translocation 1517, because the good news is we can treat this with retinoic acid, which is basically vitamin A. So that is good news, right? Because if you have the M3 type and we give you retinoic acid, which is basically vitamin A, what it does is actually convert the immature cells into mature ones, therefore curing the disease. So also remember that we cannot blast these patients with chemotherapy, because if we do, they're going to develop DIC. So be careful. No chemotherapy if a patient has M3 form, because we can just give them vitamin A and basically convert the immature cells to mature ones. But if you do chemo, the patients are going to develop disseminated intravascular coagulopathy. And to learn more about DIC, you can watch our lecture in the hematology chapter under DIC, which is a very devastating disease. And the reason why they develop DIC is because these patients release all the Howard rods inside the cells, and once this gets released from the myeloblast, it can predispose them to damage the endothelial cells, causing clotting and a massive bleeding and a lot of medical complications from disseminated intravascular coagulopathy, clotting and bleeding. Also, the M4 and the M5 is usually associated with non-specific esterases. M4, M5 are non-specific esterases. And the M5 is usually called an acute monocytic leukemia, which means it basically affects the monocytes, and monocytes become macrophages. Very good. Monocytic leukemia. And the thing you need to know about this is it affects the gum. So there's a lot of gum infiltration in the patients that have the M5 form of acute myelogenous leukemia. The M6 often affects the erythrocytes, which are the red blood cells. So there's massive proliferation of red blood cells. And the M7 affects the megakaryocytes. Megakaryocytes, which are the cells that are going to produce the platelets. So these are the FAB classification of acute myelogenous leukemia. Remembering that M3 responds to retinoic acid, which is vitamin A, and don't do chemotherapy because they're going to develop DIC. The main treatment for AML is methotrexate. Methotrexate. That is the major treatment for acute myelogenous leukemia. Acute myelogenous leukemia. So let's talk about the clinical features that patients that have acute leukemia, now thinking about when I say acute leukemia, both acute lymphoblastic and acute lymphocytic leukemia, acute myelogenous leukemia and ALL are going to present with clinically. Well, we already talked about it in the general overview. Remember, these immature cells always affects the bone marrow. So if the bone marrow is affected, we're going to affect all three cell lines. All three cell lines are going to be affected. So if all three cell lines are affected, we can easily break it down into three, right? They're going to have anemia, because the red blood cell lines are going to be affected, which is going to cause the patient to be fatigued, right? They're going to be exhausted. They're going to have pallor because they have low hemoglobin count. Also, they're going to develop dyspnea, depending on how worsened their anemia is, dyspnea or shortness of breath, pale conjunctiva, because you're going to check their conjunctiva and you're going to see it's very, very pale. Unfortunately, because they have leukopenia, which means they don't have neutrophils. They have white blood cells, but they are not functioning, right? Remember, it's the granulocytes that have been affected. So, unfortunately, they're going to be predisposed to a lot of infections, bacterial infections. What kind of bacterial infections are we talking about? Pneumonia, right? Infection in the lungs. In the urinary tract, they develop urinary tract infections, and also they can develop cellulitis, which is infection of the skin, pharyngitis, right? Infection of the pharynx, and even esophagitis, which is inflammation of the esophagus, because these patients cannot fight infection properly. Unfortunately, acute leukemia is very associated with a high morbidity and even mortality. This disease is very, very fatal, so you got to treat it very aggressively because it can be potentially life-threatening. Because the platelet count is going to be affected, they're going to be thrombocytopenic, right? Low platelets, so they cannot clot anytime they have any kind of bleeding. So they're going to have abnormal mucous membrane bleeding, also they're going to have petechia, nosebleeds, right? Epistaxis, which is also known as nosebleeds. They might have petechia, which are dot-like hemorrhages on the skin. They can have ecchymosis, which is a fancy word for a bruise under the skin. And they can have purpura, which is also a sign of low platelet counts. They're going to have a huge spleen, splenomegaly. And their liver is going to be very, very large, which is known as hepatomegaly. And they will also develop lymphoadenopathy, which is basically swollen lymph nodes. Because the bone is being affected, these patients are going to develop a lot of bone pain. And the reason is because as the cancerous cell start to spread and they infiltrate the periosteum is the covering around your bone. Once they infiltrate that and start to peel it up, they're going to start to develop a massive amount of bone and joint pain. Unfortunately, because these leukemia cells are going to migrate eventually into the bloodstream, right? Just like any regular cells, they cannot go into the CNS. When they get into the central nervous system, the patients start to have focal neurologic symptoms, and they have focal neurologic dysfunction, like they can develop meningitis, they can have seizures. Just think about it. We have a ball of lymphocytes or leukocytes, which are white blood cells. They pump into circulation, they are cancerous, and they migrate into the blood, and they get into your neurons inside the neuronal tissue in the brain, and it starts to damage them. Then what happens? The neurons start to fire and cause the patients to develop seizures. Also, in ALL, which is acute lymphoblastic leukemia, the patients can have testicular infiltration, so they can have their scrotum being affected in ALL, so testicular involvement. And if it's a T cell cancer, it can also affect the anterior, cause the patient to have an anterior mediastinal mass, a huge mass in the mediastinum. Also, skin nodules associated with AML. So how are we going to make the diagnosis of this disease? It's very straightforward, right? We order a CBC. You want to check a complete blood count. You get a CBC, and when you do a CBC, you see they're anemic, they're leukopenic, and they're thrombocytopenic. And usually the white blood cell count is usually between 1,000 to 100,000 cubic millimeter. 100,000 cubic millimeter. Now look, they are 1,000 because they are leukopenic, because remember their white blood cells are not functioning properly, and they can have a lot of white blood cells, but still they are non-functioning white blood cells. They're just massive because of it's a cancer that's just producing a lot of abnormal white blood cells, and usually this is a lot of blast cells. Blast cells. Remember, blast cells are what? They're immature white blood cells. So you see a significant amount of white blood cells, which are blast cells, inside the peripheral blood. Also, they're also going to have electrolyte abnormalities. Electrolyte abnormalities. Let's find out why they have electrolyte abnormalities. Because when you have a white blood cell, right, which is like a regular cell, inside the cell we have phosphates, right? Phosphates are usually found inside the cells. Potassium lives inside the cells, and we have DNA, right? DNA is made out of purines and pyrimidines. When these patients undergo chemotherapy, you lyse open and you break up this tumor cell. So let's say this is the tumor cell, right? And when what's going to release is they're going to release their phosphates, they're going to release all the potassium, and the purines are going to be converted into uric acid. Therefore, the patient will develop high levels of phosphate known as hyperphosphatemia, high levels of phosphate in the blood. High potassium, which is hyperkalemia, because the potassium is not leaking out into the bloodstream. Hyperuricemia, because uric acid level is going to be skyrocket when you blow up this huge cancerous cell and releasing all this content. Therefore, this is known as tumor lysis syndrome. Tumor lysis syndrome, which is a fancy word for a tumor that was blasted with chemotherapy and went to the suicide mission to release all its content, and that is what tumor lysis syndrome is. And this often happens when we treat patients with chemotherapy that have leukemia. But how can we really know what the diagnosis is? Well, we go to where the issue is, because when the tissue is the problem, is the issue, you go take a bite. So we do a bone marrow biopsy. A bone marrow biopsy, which will give us the diagnosis, because when we do a bone marrow biopsy and I see our rods, I'm like, you have acute myelogenous leukemia. If I see a lot of lymphoblasts, right, and I said, oh, wait a minute, you have ALL, you have acute lymphoblastic leukemia with a lot of blast cells. So how are we going to treat this disease? Well, usually this can be a form of an emergency. It's actually an emergency because if somebody's all three cell lines are down and they're susceptible to a lot of infections, they're anemic, and they have thrombocytopenia, the way you treat it, you basically treat each of them. So the first thing you will need in terms of treatment is to order a blood culture. The reason why we want to get a blood culture is if they have an infection, you want to blast them with a lot of antibiotics. So I'm going to put treatment under here, and the treatment is going to fall under each of them. So treating, you want to order blood cultures, CX for cultures, and you want to give them antibiotics to be able to fight any kind of infections, and if they're anemic, they might require blood transfusion, especially if their hemoglobin, right, and hemoglobin is less than 7, the patient might require blood transfusion. And also, if their platelet count is low, what do we give them? We give them platelets back so they stop bleeding. We're also going to need aggressive chemotherapy. And we talked about AML. We give methotrexate as the modality for treatment in AML. And for ALL, we usually also give them chemotherapy to be able to help the patients. Remember, ALL loves to respond to chemotherapy, but AML is very mean to chemotherapy. It doesn't like it, and most of the time it doesn't respond well to chemotherapy. But the best treatment for both of them is to do a bone marrow transplant. A bone marrow transplant, we basically take out the bone marrow, put a new one in there, and then we basically replace all the problem relating to the immature blast cell neoplastic proliferation. All right? So basically that brings us to the end of acute leukemias. Remember the highlights: ALL affects Down syndrome patient, increased risk of radiation. The same thing affects AML. Risk factors includes having exposed to radiation, and also you could have myeloproliferative syndrome, myelodysplastic syndrome, and also chemotherapy can predispose you also to AML. Those are risk factors. For ALL, remember these patients affect the pre-B cells and the pre-T cells, and from the word lymphoblastic, it affects lymphocytes. And the age is the most important thing in ALL, less than 15. In AML is 15 to 19 years old. All right, thank you very much for watching. Till I see you again, Dr. Adeshina from ftplectures.com. Have a great day. Bye-bye.